Hi, I'm Dr. Terry Schoenfeld, Associate Professor in the Department of Medicine at the University of Alabama at Birmingham. I'd like to do a little update on the new American College of Cardiology, American Heart Association guidelines on the treatment of blood cholesterol that were just published in November in Circulation. As a disclosure, several years back, I was a speaker for an unrestricted educational grant to Johns Hopkins from AstraZeneca to talk about cholesterol management and evidence-based medicine principles. I also serve on the Pharmacy and Therapeutics Committee at the Birmingham VA Medical Center, and we do make decisions about cholesterol-lowering medications. So what I'd like to cover today is to talk about how to apply the new guidelines to the care of adults at increased risk of atherosclerotic cardiovascular disease, talk about some of the limitations of the new pooled risk prediction tool, and also learn a little bit something about evidence-based medicine, about guideline limitations and prediction rules. So the Institute of Medicine has been an important player in the guidelines industry. They have come up with a new definition of guidelines, which I show here, and also standards for guideline development, which we'll get to on the next slide. But importantly in this definition is that guidelines should assess both the benefits and the harms of a treatment when making a recommendation. And the implicit thing here, which they don't say, is this involves biases and value judgments that are made by the guideline developers. To go from data to a recommendation goes through the filter of the guideline developers and affects the recommendation that they make. It's the only way to explain multiple guidelines on the same topic that look at the same literature and come up with different recommendations. So keep that in mind, that many guidelines are filtered through the values prism of the guideline developers. Now, as I mentioned, the Institute of Medicine came up with several attributes that guidelines should have to be trustworthy. It goes without saying that they should be based on a systematic review of the existing evidence. We really don't want guidelines that are just expert opinion. There should be a multidisciplinary panel of experts that develop the guideline. Unfortunately, many guidelines are single specialty developed, which I think is a real problem. They should incorporate patient preferences, and here's where a lot of guidelines fall down. After all, we're applying these to patients. Patients have to make a decision, and we should involve them in the decision-making process, or at least make the recommendations explicit to where patient preferences come into play. There should be a very explicit and transparent process, and most guidelines, even though they'll spend time saying we followed a very specific methodology, it's very difficult to find that methodology, and it's very poorly documented so that you can look at it as a user of the guidelines. So a very problematic area for guidelines, especially in this day and age where so much could be posted online, that they just fail to do this. They should discuss alternative healthcare options and the outcomes that result from them. Hopefully that makes sense. They need to rate the quality of evidence and the strength of the recommendation so you get some sense of how good the evidence is that a recommendation is based on. Just because an expert comes up with a recommendation doesn't mean it's based on solid evidence. It may be their opinion only, and I always worry about opinions. And finally, they need to be revised in a timely fashion. And unfortunately, these cholesterol guidelines, the ATP3 was a long time ago, and it took a while for these new guidelines to get updated. So I want to talk about the good, the bad, and the ugly in these guidelines. Let's focus on the good. I think a great thing these guidelines have done is they've taken away the LDL target that we all were forced to shoot for. So there's no LDL targets anymore. And it's a statin-only guideline, so no more add-on therapy. And largely it's because we've taken away that LDL goal, so there's no need to add other medication. It's really the statin that's important. It's the other things that statins do that make the difference here. And I think also importantly is they really focused on very high quality randomized controlled trial data or systematic reviews of those high quality randomized controlled trials. So moving away from less rigorous evidence was an important step for this guideline. So this figure here is the entire guideline, and what we're going to do is go through each component of this and focus and break down each of the individual steps when considering starting a patient on a cholesterol lowering medication. Now, there were 4 groups that were identified by the guideline developers as being groups that will benefit from statins. So a group of patients who already have clinical atherosclerotic cardiovascular disease, a group of patients with familial hypercholesterolemia and very high LDLs, patients with diabetes, and then the controversial area, which we'll talk about, is the primary prevention group who have elevated cardiovascular risk. So let's go through each of these groups individually. We'll first start off with patients who have clinical atherosclerotic cardiovascular disease, and the guideline breaks them up into those who are less than 75 and those who are over 75. And if you have atherosclerotic cardiovascular disease and you're under 75, you should be on a high intensity statin. And if you're over 75, you should be on a moderate intensity statin if you're not a candidate for a high intensity statin. I'll talk about what high and low intensity means in just a minute. So atherosclerotic cardiovascular disease is denoted by these things: acute coronary syndrome, history of MI, angina, being revascularized, having a TIA, stroke, or peripheral arterial disease. So if you have any of these elements, you're considered having clinical atherosclerotic cardiovascular disease. And the reason they sort of put a very focused fixed dose statin is that there were no randomized controlled trials that they identified that titrated drug therapy to specific LDL goals. Now, there were some studies that had people on lower dose or higher dose, but they weren't based on specific LDL goals. They wanted to see if higher dose was better than lower dose. So this is the reason that they have a very focused single dose sort of statin approach in this particular guideline. Now, high dose statin is a dose which will lower LDL by greater than or equal to 50%, whereas a moderate dose statin lowers your LDL by 30 to 50%. And this is a table from the guideline. High intensity statins are largely atorvastatin 80 milligrams or rosuvastatin 20 milligrams. Now, in parentheses in this table will be times in some of the studies that they either reduced their dose or titrated up a dose, but it wasn't to get to a specific LDL goal. So high intensity is atorvastatin 80 milligrams or rosuvastatin 20 milligrams. And you can see here what the various medications are that meet moderate intensity statin therapy. So keep this in mind. If they call for high intensity statin, use one of these two drugs. If they call for moderate intensity statin, you can use a variety of other drugs. But try to get to these doses. It's the only way you'll get the desired LDL lowering. So the second group for which there was definite benefit from statins were patients with largely familial hypercholesterolemia with very high LDLs, over 190. And these patients really need high-intensity statin to get their LDLs down into a reasonable area to lower atherosclerotic cardiovascular risk. And because these are often genetic, it's really recommended that families undergo screening for their lipids also. And you must also, in these very high LDLs, consider secondary causes of elevations in LDLs. Now, I'm going to ignore the elevations in things like triglycerides for this particular talk, but I want to focus just on LDL. So there are various drugs that can raise your LDL, like diuretics, cyclosporin, glucocorticoids, amiodarone. Biliary obstruction and nephrotic syndrome can both raise LDL cholesterol, as can hypothyroidism and pregnancy. Now, one thing to keep in mind, if a woman is pregnant, that statins are contraindicated in pregnant women and in women who are lactating. So keep that in mind if you feel that an elevated LDL is due to pregnancy and you want to treat it, you may have to use an alternative therapy. Diabetes is the third group that is recognized as benefiting from statins. And you'll notice there are two boxes here, a green box, which means there's very high quality evidence and a strong recommendation, and then this yellow box. So in all diabetics, you should consider at least moderate intensity statin therapy if they're between the age of 45 and 75. Now, we'll talk about this risk later, but if patients with diabetes are at very high risk, you might consider a high-intensity statin. We'll talk about this risk prediction tool later and what I think are its limitations. But no matter what, diabetics, if they're between 40 and 75, should be at least on a moderate-intensity statin, maybe a high-intensity statin, as we'll talk about later. And the reason that box is in yellow is that there is extrapolation of data from primary prevention trials in high-risk patients, and in this case we consider high risk greater than 7.5%, who didn't have diabetes as benefiting from statin therapy. So there wasn't an exact trial in diabetics in high-risk group. It's an extrapolation of primary prevention data to them. So again, this is expert opinion. There was conflicting data in studies, so that's why it gets a yellow box. And we'll talk a little bit more about this later when we talk about this risk tool. Now, what if a diabetic is less than 40 or over 75? Well, this decision to initiate statin therapy should be individualized in this patient. And this was based on their expert opinion, and there were some divergent opinions on this. And we'll talk a little bit more later about people at these different ages, either less than 40 or greater than 75, and deciding whether to start a statin. Have a slide on that later. So finally, the most controversial area of this guideline was this part of primary prevention in using a newly developed risk tool to determine a patient's risk and to decide on whether you're going to initiate statin therapy. They also lowered the cutoff from previous guidelines to 7.5% here, whereas in ATP3 the guidelines recommend a much higher risk cutoff before initiating statin therapy. So an area of controversy, which has led to some editorials and some opinion pieces in a variety of journals and online discussing this. But either way, the authors recommend estimating a patient's 10-year atherosclerotic cardiovascular disease risk with their new pool cohort equations, and if risk is greater than 7.5%, that you initiate a moderate to high statin intensity. So the higher the risk, you might want to consider a high-intensity statin. If they can tolerate it, if they can't tolerate it, you might want to use a moderate intensity statin. Well, again, we'll talk about this a little bit later about this risk tool. And the authors furthermore say, even though it's not on this graph, that it's reasonable to offer statin therapy to those whose risk is a little lower, between 5 and 7.5%. And this was based on conflicting evidence, gets a little bit lower grade. And we'll talk again about this concept of deciding whether to start lower risk people on statin therapy in a few slides. So let's look at some data on primary prevention and see if it makes sense to do this. So this figure was published in JAMA Online in a clinical evidence summary, but it's from a Cochrane systematic review on statins for primary prevention. And what it has over here along the left side is a variety of outcomes, has a number of trials, number of participants, etc. Over here, this forest plot shows the point estimates of this meta-analysis for each of these outcomes. This dotted line here is the point of no difference because it's a relative risk. Anything to the left of it means statins improve the outcome. Anything to the right means the control group had it improved. And finally over here, importantly, it shows the number needed to treat for 5 years to prevent one additional one of these events over here. Now again, I did mention this is a Cochrane systematic review that was summarized here. So one of the things you can see for primary prevention, statins reduced pretty much all the major outcomes of all-cause mortality, total cardiovascular disease events, coronary disease events, strokes, and the need for revascularization, significantly reduced by statins in primary prevention. You can see the numbers needed to treat over here. So I think number needed to treat is important to consider because a lot of physicians have a black and white approach, unfortunately. We think everything we do helps people, but you can see you have to treat a few people for one of them to gain benefit who wouldn't have gained it otherwise. So don't always think that just because we start a drug, it matters in everybody. Importantly, in this Cochrane review, adverse event rates, and that was a variety of things like myopathies or muscle complaints, transaminitis, etc., were exactly the same in the folks who were randomized to statins and those who were on placebo largely. So in this particular meta-analysis, there was no increased risk in all the symptoms that we see in patients. Patients on placebo had the same exact event rates. As we have seen, the authors of this meta-analysis did detect an increase in type 2 diabetes in patients given statins. The number needed to treat was 99 here. So for every 99 patients that you treat with a statin, you'll cause one excess case of diabetes that would not have happened otherwise. And the caveat of all these primary prevention studies and the meta-analysis I present here and on the next slide is that these are largely healthy individuals who are 40 to 75 years of age without serious comorbidities. They weren't taking a lot of drugs that would lead to statin interactions. So you got to keep that in mind, that these are probably a little bit different group of people than we often see in practice. And as we'll talk about later, one of the options for deciding who to give statin therapy to for primary prevention may be just thinking about the inclusion criteria for these primary prevention trials. This may be a starting point for you if you don't believe and don't like the new prediction tool as a way to decide who gets on a statin. There was another meta-analysis published in Lancet in 2012, the cholesterol trialist treatment group meta-analysis, and it found similar efficacy findings to the Cochrane meta-analysis. They did find, though, increased risk of myopathy in patients on steroids with a number needed to harm of 2,000. They found diabetes like the Cochrane review did with a number needed of 200. Remember that number needed to harm in the Cochrane was 99. And they found an increased risk of hemorrhagic stroke, again with a number needed to harm of 2,000. And they importantly found no reduction in cardiovascular disease events in patients on statins who had heart failure who were on maintenance hemodialysis. And this guideline does not make any recommendation for giving statins to patients with class 2 to 4 heart failure or who are on maintenance hemodialysis, because there was no reduction in cardiovascular events in these people. Important group to keep in mind, because these are very high-risk groups who die often of cardiovascular problems, but statins just have not been shown to reduce cardiovascular events in these patients, unfortunately. Now, this is a graph from that CTT meta-analysis, and what I think is important, and what this shows is, so on the side here you can see these are major vascular events, these are vascular deaths down this lower graph. These are amounts of LDL lowering in millimoles, and I put down here that each millimole equals about 40 milligrams per deciliter of LDL cholesterol. Along the sides of the graphs are the risk categories of patients from low risk all the way up to very high risk. And these bars with the numbers in them show the number of events averted by statins. So you can see in this that even in low-risk patients, they do gain some benefit from lowering LDL cholesterol with statins. And obviously, the higher the risk you are and the greater you lower the LDL, the greater is the benefit. But I think the important take-home point here, especially for primary prevention, is that even very low-risk groups of people will gain benefit and have major vascular events averted and vascular deaths averted by giving even very low-risk people statins. Important point to remember. So what do I view as the bad of this guideline? Well, I think conflicts of interest, which is present in almost all guidelines, were a real problem in this particular guideline. And one could argue, and many have in some editorials, that the increased statin utilization, the so-called statinization of the world, if you will, is a problem for many people. And we'll talk about this. So what about conflicts of interest? Well, there are two main types. They're financial and intellectual. So financial conflict of interest, you stand to gain yourself from a recommendation that you make financially. Intellectual conflicts of interest are a little bit more hard to think about, but it's really you believing in what you're going to recommend, and you just can't get away from your beliefs. So I personally believe that applying EBM principles to patient care is very important. You're not going to get me away from those beliefs. So I'm going to make recommendations to my residents about learning these techniques and trying to apply them in the care of patients. Urologists had very strong beliefs about PSA and digital rectal exams for prostate cancer screening. It was very hard for them to give that up in making recommendations about prostate cancer screening in adults. So keep that in mind, that our intellectual, our research, our knowledge about a particular topic is often very hard to overcome and conflicts us when we try to objectively look at evidence and making recommendations. And per the Institute of Medicine principles on developing trustworthy guidelines, hopefully this all makes sense, that whenever possible, guideline development groups, the members of those groups should not have conflicts of interest. And if it's impossible to not have any conflicts of interest, the minority of people on the guideline panel, the vast minority should not have any conflicts of interest. Importantly, the chairs and co-chairs should not have conflicts of interest. And then the funding agency should have no role in clinical practice guideline development. So hopefully this all makes sense. One could argue about dealing with conflicts of interest. There's been a lot written about this. One could even argue even more of how you deal with conflicts of interest. It's not the point of this. What we want to do is focus on, importantly when we read a guideline, is what impact potential conflicts of interest could have had on the guideline recommendations. Now, at a bare minimum, conflicts of interest should be disclosed, and this shows you all the things you should disclose. And the Institute of Medicine really recommends that any guideline development panel member should divest themselves of all financial interests both them and their family have while they're involved with the guideline development. Now, there was a paper published recently in British Medical Journal with the title, "The Majority of Panelists on the Controversial New Cholesterol Guidelines Have Current or Recent Ties to Drug Manufacturers." Neil Stone is a cardiologist who was the chairman of this panel, and he discloses that these various companies he had financial association with either as sort of speakers bureaus, be a consultant, getting research dollars from them. And importantly, AstraZeneca is the maker of rosuvastatin, and Pfizer is the maker of atorvastatin. So two statins which play prominent roles in the new guidelines. And furthermore, Dr. Stone said he would not take industry funding for 2 years after the release of these guidelines. Jennifer Robinson, one of the co-chairs, had current financial ties to statin manufacturers while on the panel and the guideline recommendations were being developed. Many of these were research associations, but were financial ties nonetheless. And unfortunately, 6 of the 8 panelists had financial ties while they were serving on the guideline development panel. I clearly feel this is a big problem, that these conflicts of interest exist. There's no way to dissociate yourself, no matter how much you disclose, from your conflict of interest, at least at a subconscious level, impacting what you recommend. Now, the members with conflicts were asked to recuse themselves for voting on any aspect of the guideline in which a conflict might exist. And importantly, independent contractors, so people outside of this group, did the systematic review for the questions that the guideline developers had, and they reviewed the evidence independent. So hopefully these contractors didn't have conflicts. They don't really say much about them. And what you always have to ask yourself, and what I ask, is what effect did these conflicts of interest have? They had to have some impact. I personally believe in many of the recommendations that they made, but you have to wonder, if you took a group of other guideline developers who didn't have any of these conflicts, would they have come to the same recommendations? So is it a problem that we're going to increase statin utilization by applying this guideline? And it's been shown, and we'll talk about in a minute, that the new risk calculator overestimates risk. It labels people as being higher risk than they possibly really are. And then they lowered the threshold to initiate statin therapy. No matter what, this is going to lead to more people being on statins. Some people believe this is a real problem. Some have no problem with this. And I'll show you my take on this. I showed you evidence on primary prevention working in all risk level groups. So you'll have to decide for yourself if giving more people statins is a good thing or a bad thing. Now this is going to be a calculation made, as I'll show you in a minute, from a publication that 101 million people in the U.S. aged 40 to 79 years of age don't have cardiovascular disease. 33 million of these are expected to have a risk by this new prediction tool of greater than 7.5% and will be a candidate for statin therapy. 13 million people have a risk between 5 and 7.5%, and the guidelines recommend that you really consider statin therapy in this group of people. So the U.S. population is 1/20th of the global population, this age range, who is at increased cardiovascular risk. And if you put these two groups of people together, multiply it by 20, you come up with 920 million people worldwide who would be new statin candidates if you apply these guidelines worldwide. Some people have a real problem with this, as does this author who published this manuscript online earlier this month. A lot of new people will be on statins if we apply these guidelines with this risk prediction tool. So is this a bad thing? I certainly showed you earlier from the cholesterol treatment trialist meta-analysis that even people at very low risk with minimal reductions of LDL will have prevention of major vascular events and vascular death. MI and stroke are leading causes of death in the United States. And what this figure tries to show from Health Affairs is that there's a large social value in broadening statin prescriptions across this country. So the costs are in this red bar. The benefits clearly greatly outweigh the cost by 4 to 1, suggesting that it's not a bad thing to expand our statin utilization. So what do I view as the ugly in this guideline? Well, it's this risk prediction tool because it overestimates risk. So let's just take one step back and talk very briefly about what clinical prediction rule development looks like. First thing you have to do is derive the rule. You find factors that hopefully have predictive power statistically of the outcome that you're looking at. Next, you need to validate your rule, and the bare minimum is what I call narrow validation. It's applying the rule to a similar group of patients, and often what authors will do is take a population of patients, split it in half. On one half, derive the rule, and then test the rule on the second half. That's a bare minimum validation that we should see. We want to see is more broad validation of applying the rule by multiple clinicians in multiple different clinical settings with patients at varying risk of disease to see how good the rule does. And then finally, what we really want to see is something called impact analysis, where we see if applying the rule in clinical practice really improves behavior of physicians applying the rule or improves patient outcomes. Where we are right now with this tool, for sure, we had narrow validation. And I'll show you some data that it was used a little bit in a different population and didn't perform very well. So why did these authors develop a new risk prediction tool? So they felt Framingham, which we were all very familiar with, was just not adequate because it was derived in an exclusively white sample population with very limited outcomes. They only really looked at coronary heart disease alone. And this is true. When Framingham was developed, Framingham, Massachusetts was a very homogeneous population of white people. They also felt other risk scores which exist, and there's several of them out there, suffered from, quotes, non-representative or historically dated populations with limited ethnic diversity, with very narrowly defined endpoints, endpoints that were influenced by provider preferences, and endpoints with poor reliability. So it made sense to them that they needed something better. And so importantly, and I think to their credit, their risk tool has a much broader outcomes of interest. And I define what atherosclerotic cardiovascular disease was before, but it really looks at much more than other tools have looked at. And this is commendable. So clincalc.com is a website which has the risk prediction tool on it. You can also get it for your Android or Apple device. The authors of the study did provide a tool on their website, but it's an Excel spreadsheet, which is god-awful. Why would you develop something that is 90s technology that can't be used on devices which you can't use Excel on? So I think ClinCalc has done a better job of having this online calculator, and then you can purchase, I think for only 99 cents, the app to put on your phone. And it looks very nice and works very well. So what did the authors do to derive and validate their tool? So they used some recent National Heart, Lung, Blood Institute-sponsored cohort studies, namely the ARIC study, the Cardiovascular Health study, and the CARDIA study, along with some data from the original Framingham study and the Framingham Offspring study to develop predictors of atherosclerotic cardiovascular disease. They use a variety of statistical models like we always do, including these covariates and the covariates I showed on the last slide. So the things that worked out to be predictive were your gender, age is the biggest driver, race, total cholesterol, HDL cholesterol, systolic blood pressure, whether you're on treatment or not, diabetes, and whether you're a smoker or not. Notice LDL cholesterol is not in this prediction tool and was not in the Framingham tool either. And for validation, they looked at discrimination and calibration like most tools do, and they also externally validated this cohort in two groups of people, the MESA study and the REGARD study, and also some contemporary cohorts from ARIC and the Framingham cohorts. So let's talk a second about validation, discrimination, and calibration. So discrimination means, will your tool accurately assign patient as having disease or not having disease? It's as simple as that. Is it right in assigning patients being diseased or not? And classically what's done here is a C statistic or an area under a receiver operator characteristic curve. Calibration is how well does the predicted risk estimate match the observed risk in an external population. So we can have a group of patients, we know what percentage of them or what numbers of them developed the outcome. We can see how well our tool meets that. Often a calibration curve. There are also some other statistical techniques that are used. So this is from the website, accompanying information from the guideline. And what I want to focus on here is the C statistic. So the C statistic, again, is a measure of discrimination. It's a measure somewhat of overall accuracy of the tool labeling people as having disease or not having disease. And a C statistic can range from 0.5 to 1. A 0.5 C statistic means the tool is absolutely useless. It's just as good as a coin flip, whereas 1 means it has perfect discrimination. So reasonable discrimination is if the C statistic is 0.7 or greater. Strong discrimination is if it's 0.8 or greater. So what I want to look at, and up here we have in this top table we have white people. In the bottom table we have African Americans. In the left half we have women. The right half we have men. And again, focusing on the C statistic, I don't really care too much about it from the derivation cohort. You can see some of them aren't great. So in this regards database, not too great. It didn't reach reasonable levels, and it particularly wasn't very good, almost as good as a coin flip in men in this particular group. Same thing down here in African American men. And remember, they designed this or wanted to develop a new tool because they wanted to be better in predicting in African Americans. And there's some evidence that it might not be as good as they had hoped in African Americans. Certainly almost as good as coin flip in African American men in this particular group, which is the biggest group, and not much better in African American women. So keep that in mind, that this tool just isn't very discriminatory. And when they look at calibration, in this particular case, it's a variety of those cohorts, again, the MESA, regards, and some contemporary cohorts. The blue is what absolutely happened to these people. It's the observed event rates. And the red is expected. And you can see in almost all cases the expected risk or expected event rates in these people in these different cohorts were much higher than what was observed. So the tool overestimated risk in these patients by a significant amount, as you can see. Probably absolutely the first person to critique these particular guidelines and the problem with the risk tool was Paul Ritker and Nancy Cook. Immediately upon guideline release, they had an editorial come up on the Lancet, and this is the reference up here, and they looked at applying this tool to the women's health study, the physician's health study, and what I don't show here is also an observational component of the Women's Health Initiative. And in each case, again, similar to that last calibration curves, the blue is the absolutely observed event rates in the women and men in these particular studies. In the red is the predicted event rates by the new prediction tool, and in some cases it overpredicts by up to 150% the risk of this population. So this is a problem, and you have to ask yourself, how many of the 33 million new people expected to have risk greater than 7.5% actually have risk that high? Remember, I showed on that slide earlier that based on a conservative estimate, 33 million new people will have a risk greater than 7.5% and should be on a statin. You got to wonder how much less people might need a statin if you believe that giving statins to a lot of people is not a good thing. So what should you do about risk assessment? This is my opinion. It's not from anything. So one of the things you could do is just use the new equations, understanding that there's probably a little bit of overestimation of risk, and say, I don't care. I think statins are a great thing. More people should be on them. You could use other traditional risk scores, which we have used and have been validated, like Framingham. There's Q-risk, and there's a nice paper in the British Medical Journal from 2012 reviewing the various risk tools that are out there for cardiovascular disease. It is open access, so it's something you could get freely online, and the title is Comparison of Established Risk Prediction Models for Cardiovascular Disease, a Systematic Review. So if you just Google that, you'll find it. The third thing you could do is ignore any risk assessment and consider that almost everybody benefits from primary prevention and just put people on statins. It's a reasonable approach. As I showed you, even people at the lowest risk gained benefit from being on statins. Finally, I think what you could use is use the eligibility criteria from primary prevention trials and decide on using statins this way. This will miss some people. Remember, I showed you that it's a very sort of healthy group of people, not on a lot of drugs, not with a lot of comorbidities, who get into these types of trials. So you're going to miss some people who would gain benefit from using this approach. But it is an approach that would be considered very evidence-based. So what are some other recommendations from this guideline? So they recommend in lower risk people, people who have 5 to 7.5% predicted risk, or who are less than 40 or over 75, that you should discuss with your patients the following 4 things and help make a decision on whether you wanted to use statins. So you could talk about the risk reduction benefits from statins. And on average, there is a 30% relative risk reduction from moderate intensity statins, that's what MIS stands for, and a 45% risk reduction from high intensity statins. So you could start out with your patient's absolute risk, multiply it by the relative risk reduction, and you could see what their resulting risk might be by giving them a statin. You can help them make a decision. You should talk about the adverse events, effects of a statin. Remember, diabetes had a number need to harm, depending on the meta-analysis you looked at, anywhere from 90 to 200. You should talk about drug-drug interactions and see what medications the patient's on, and you don't obviously want to give them and drugs which interact with each other. And finally, see what your patients think. Do they want to be on a drug for the rest of their life or not? Do they want to take the risk of not being on a drug for the rest of their life? So these are the 4 things that it's recommended, and probably we should do this anyway, even when we're going to start higher risk patients on statins, to take into account other things which impact this decision. The other thing is to consider in these lower risk individuals is that family history of premature coronary artery disease, and that's males less than 55 or females less than 65, that might be an important decision maker in these patients starting a statin. Though it's not specifically recommended to do a coronary calcium score or measure a highly sensitive CRP, if you have that information, if their CRP is over 2 or their coronary calcium score is over 300 or greater than the 75th percentile for their age and sex, that this may be an important decision maker in deciding to initiate a statin in these patients. They also recommended that CK, or creatinine kinase, should not be routinely measured in patients to either screen them up front for myopathy or to just routinely follow them after they're started on a statin. You should really only measure CK if patients develop symptoms of myopathy. They do recommend measuring a baseline ALT, and if it's very high, obviously you would not want to start a statin, and only remeasure the ALT if symptoms suggest hepatotoxicity. So there's no reason to routinely check ALTs in patients who are on a statin. You should screen for diabetes just by following the current screening guidelines by the American Diabetes Association. Now, if patients do develop muscle symptoms, they've taken a very algorithmic approach of how to approach this. So you should temporarily discontinue the statin and assess whether the patient has rhabdo if their symptoms are severe. And then also look for other conditions that could cause muscle symptoms. There are a variety of rheumatologic problems, things like hypothyroidism, that could cause muscle symptoms. If you ruled out all those things and you think it might be a statin, they recommend actually re-challenging the patient with a lower or same dose of that same statin that caused problems. And if the pain comes back again, then you have some evidence that it's that particular statin which causes a problem. But it's important to them to figure out that particular statin, and again, remember, statins have been shown to be very powerful reducers of atherosclerotic cardiovascular disease. So they really are value patients being on statins in this particular guideline. If the statin is causative, they recommend giving a lower dose of a different statin, and if they tolerate it, then titrating up that statin to the highest possible tolerated dose. Again, we want to get to either moderate or high intensity based on the patient's risk profile. There's no recommendations made for add-on therapy to lower LDL after optimal statin dosing. They are going to look at this in a future guideline, but as of now, you really should not be adding on other drugs like niacin, like ezetimibe, to try to lower LDL further, because there is no LDL target. It's a statin-based guideline. Now, they do have a separate guideline on triglycerides published in Circulation in 2012, and they very specifically mention if patients' triglycerides are very high, in this case only if they're over 500, should you consider treating with fenofibrate, no gemfibrozil, because gemfibrozil has a much higher risk of leading to muscle complications if patients are on statins. And the benefits are judged to outweigh the risks. So I invite you to review that triglyceride guideline. There's some other very good information in it that I think is applicable to all of our patients. But keep in mind that triglycerides really only become a problem when they're very high and causing pancreatitis. Now, the authors don't specifically say we should titrate to any LDL target, and in fact, they've removed that. But they do say we should consider rechecking a lipid panel 1 to 3 months after initiating therapy just to assess for adherence, but not to adjust therapy per se. So you just want to see if your patients are taking the statin as we prescribe. I worry about this recommendation and that people are then going to go back into old habits of wanting to add on things or change things to get to a particular LDL goal. Remember, it's not the point of this guideline. LDL goals are gone. It's a statin only and really titrating to a maximally tolerated dose of the statin. So in summary, here's the whole flow chart. One of the things I didn't focus on earlier is healthy lifestyle habits are the foundation of atherosclerotic coronary vascular disease prevention. So patients need to be on a good diet. They need to be exercised. They need to stop smoking. Things like that are very important in the cornerstone. We focus so much on a drug, but really that is very, very important. It also is important to realize this is a very young group of people who we're considering starting statins in. It really applies to all adults over age 21. Even though the majority of things focus on people 40 to 75 years of age, you really need to think about it in younger people, and if nothing else, getting them on lifestyle modification. Again, these are the four groups: patients with clinical atherosclerotic cardiovascular disease, primary familial, usually LDLs very high of over 190, patients with diabetes, and patients with elevated cardiovascular risk by the new risk prediction tools have been shown to benefit from statin therapy. And then you can see the variety of statins that we should be using in these patients. And finally, I'll leave you with this cartoon, which came out almost immediately from the daily costs after these guidelines were presented. It's clear this cartoonist doesn't believe in giving guidelines so much to society. And I leave it up to you to decide if expanding statin utilization is a good thing or a bad thing.